Good morning, ladies and gentlemen and colleagues. My name is Dr. Alex Andema. I am the Hospital Director, Rural Regional Referral Hospital. Today, this morning, we have a plenary session, and as announced earlier, we shall have two presentations. One will be physical, and the other one will be online. The third presentation will not take place. That was supposed to be by Paul Mbaka of Ministry of Health, Department of Health Information. We are going to start with the overview of health facility quality of care program implementation in Uganda. This will be by Dr. Martin Sentiona of SCAP Department of Ministry of Health. And this will then be followed by a keynote address, which is minimizing medical errors in health services in Uganda, by Professor Tumwine James, who is going to make his presentation online. He's already online with us. A little about Professor Tumwine. He's a professor of pediatrics and child health in Kabale University. He's also a professor emeritus at Makerere University College of Health Sciences. He has an interest in research, ethics, and training at all levels of health workers. Thank you so much. Without wasting time, since we're already a bit late, I'm going to invite Dr. Martin Sentiona. Please come and make your presentation. Thank you so much.
Thank you so much, Dr. Alex Andema. Good morning, everybody. Good morning to you all. Yes, we are happy to see you once again. I've been introduced. I'm from the Department for Quality of Care, SCAP, Standards, Compliance, Accreditation, and Patient Protection. We're in charge of quality of care in the sector. And this morning we take the opportunity to discuss a topic or something many of you, I'm sure, are involved. HHFA, as we call it, is now a familiar topic or item that we're implementing in the health sector. And we have been doing this for some time, and we think we have come at a moment now where we need to embrace it. To embrace it and note is something we need. It is something that can take our health sector forward. So I'm going to share the report, a status report. It's a status report where we are, and maybe we learn from one another what we need to do to make this work better. So those are the things I'm going to discuss by a brief background, the assessment that has been done all along, and the results, some lessons we have learned, and what are the things we need to put into consideration. That's the background. Hope you can read the colors. Why HHFA? HHFA is Health Facility Quality of Care Assessment Program. It's an assessment on implementation of service standards. It's as simple as that. You know the service standards? The standards is what you are supposed to do, the minimum, the acceptable performance for interventions. So these interventions we are implementing, we are assessing them. We have been doing this for some time, and we hope it can help us to identify the gaps, areas for improvement, and we talk about quality improvement. So it is that kind of, it's a package that we are handling, and we feel we need it. It's very important for us. It's something we need to be doing annually, at least annually in our facilities, from external, somebody doing it, the assessment. And in the other quarters, we address the gaps. We address the gaps, and then also we assess ourselves, the internal assessment. The objective for this is basically to provide regular information. The IT has gone off. The objective is to provide regular information on quality of care. That's the main objective. And general functionality of our facilities, both private and public. And we use this information to really address the gaps. I think I'm repeating myself for emphasis. You assess, you see how you are performing, and then you see the gaps, and you address them to improve the quality of care. Now, in this HHFA, we have what we call them domains. We have how it is organized. Have the domains. They are really a reflection on the 6 building blocks of the WHO, which I'm sure many of you are familiar with. These are the leadership and governance, human resource, health financing, health information, medicines and vaccines, supplies, and then we have service delivery. The 7th edition, which is which is not the commonly known with the WHO's building blocks, is client focus, or client-centered and patient care. So from these domains I've mentioned, we come up with the modules. There are 10 modules or subunits, which then define, from which we define the service standards. There are 110 service standards. So the service standards are derived from the WHO building blocks. So whatever we are dealing with when we are there and when we are working together, know that we are working around those elements. The leadership and governance is first one, very important. Human resource, health financing, okay, health information, then medicines and health supplies, and then service delivery, and I've said we add client focus. IT is not behaving this morning. I don't know what's not happening, but I think let's try to continue slowly by slowly until it resurrects. So we have assessed facilities in all the regions in the country. There are 16 regions, and we have been there in the assessment from all the way from West Nile up to down in the south, in the east, and all the regions as we know them. And we have been able to assess the facilities. You go to slide number what? Facilities assessed. Continue. That one, yeah, that one, yes. So that the facilities, that assessment you have done. We have the regions, the traditional regions, actually, and call it sub-regions, but now we talk more about the hospital zones. Regional referral, hospital zones, and should be more familiar with these ones, especially the managers, because when you're planning, and now we are reflecting more on the new approach of regional support mechanism. You have to know your regional referral hospital zone and the catchment, the districts within that catchment area. So we have, as I mentioned, we have covered all of them. Bukedi doesn't have a regional referral hospital, but number 11, that is Masaka, and the South Central, you have the Kayunga and the Entebbe, and West Nile has 2. now Yumbe and the Arua. So we strongly encourage the planners, the implementers, to be very familiar with your region, because we want to promote the tradition and practice of working within regions than working as an individual district or individual regional referral hospital. You are more impactful when you have the working as a region. And you have looked more at the public and the PNFPs. And there's also work going on for the private. We're using the squeeze tool. I talk about it later on. So we are trying to cover as much as possible. And that's what I'm sharing with you. And I'm showing you can see the facilities covered and at different levels. And next slide, I think, will give us more information about the coverage. So that's the number of the facilities assessed, 1,836, a big number. And over these, you have the 45% are government owned, 15% is PNFP, and then 40% is private. I think it's important to note this. Sometimes when I hear people discussing from the PNFP world, if I can use the word, they talk about more than 40% contribution. It is 15% PNFPs as far as, that's the data we have from the master health facility list. And we have covered all the regional referral hospitals in the assessment, and we hope we shall continue to be consistent. And I explain why, using it as a proxy. I can even say it's a cost implication. We can mark work, I think, as we proceed, we want to institutionalize the assessment practically within the regional referral hospitals. But remember, we have the national referral hospitals and the super specialized service delivery centers, which we have not touched yet, and we need to think about these ones. U-Gift, I'm sure some of you know this, has been very useful in giving us financial support. This GOU funding, and it's covered predominantly the Health Center 3s and Health Center 4s, more so to do with the RBF, result-based financing, and has yielded very good results. And we need to appreciate this as one of the areas of dealing with HHFA. As I mentioned, the private facilities, they are doing some work. Uganda's Federation, I don't know that they are here, but we need to do a lot more. It is still an elephant, the private facilities. There are very many, they are growing every day, and they are in different forms. Even the drug shops, they sell medicines, then behind there they are seeing patients. So there's a lot of work to do in that regard. But the good thing for now, we have covered all the regions in the country, and we have like a baseline data that we can use for planning and also for addressing issues to do with quality improvement. Next slide. I can use them. I've forgotten that I have the gadget here with me. So that's the coverage, I think, for the countrywide, as I've mentioned, the total, the PNFP private, and the public. So when we are working also in our facilities, in our regions, we have to put this one in mind, that we have the private, we have the PNFPs, and we need to work together, not leave anyone behind. And again, this is, I think, a more detailed description showing what has been done. And some regions have been able to cover quite exhaustively, like West Nile and College, Kigezi, Busoga, Langna, Choli, and Karamoja. I think West Nile and Karamoja have been very, very much involved in HHFA to bring results that we have, and want to appreciate the actors that have been involved. The coverage for Health Center 3 and Health Center 4 is countrywide. It's almost the whole country, and I think this is good progress. The center tools are very many, and it makes the exercise, I think, more costly. The modules, as they have been covered, you can see the performance across. In general terms, leadership and governance are scored quite well, 73.1. And when you go down, diagnostic services, we still need to do more, 47.7. And the others, as indicated, clinical and surgical, community and the referral services follow health infrastructure. But again, as you go down, the issue of medicines and the vaccines remain a challenge. So this is the general performance, but maybe we still definitely need to do and perform better and improve. So this is again the modular performance over the years, the period of years from 2021 to 2023. And you can see the progress has been happening, improvement in the different modules. By and large, apart from the diagnostic services, I think we need to sit down and see what are the critical issues. And I know a lot of investments have been made for diagnostic services. So maybe we need to see and appreciate what areas are there for us to improve. Leadership, what is there, I still told you the score, but the governance structures being operational is what we look at, and they being functional, constituted, holding meetings, and also having actions for the work, what they agree being implemented. For the clinical community referral, which follows, the tools being available and the audits and the functional referral system being in place, regular ward rounds and emergency services. Then diagnostics services where the performance is really wanting, the tracer, laboratory supplies, radiological and imaging services being available, inventory, storage. Some of those the basic items, when we go for the assessment, we don't have them, or they are not working. The BP machine, weighing scales, mark tapes, and the others. So we need to look into this in our respective places of work. Tracer medicines, it was at 51.8, as I showed to you. Some medicines are available, and we want to appreciate NMS and the department responsible for this. Essential medicines, the antimalarials, ARVs, anti-TB, and lab supplies. These are the things we look at. But also there is an increasing notice of lack of NCD medicines and supplies in many facilities. So then I'm going to go through the stars, because when we assess you, we give you a star. And I think we have not been, what has been lacking when we leave, the facilities we don't leave anything to show whether it is a star 1, star 2, star 3, and it's something maybe we shall be addressing in the future. But the stars, as you see in this period of assessment, the star zeros, you can see them as they appear on the screen, up to star 5. We want to appreciate there's a great improvement in health facilities performance, say, with the 138 facilities having star 4 and 11 having star 5. Especially the star 5, I think in the course of the day, we shall know them, and the ministry, we may have to appreciate them. Lango region having the highest number for star 4. They are 20 and 5. And I think we need to clap for Lango sub-region. And then, we've got the North Central. North Central is the Masaka, as I mentioned. It is also doing quite well. It has 15, but only 1 star 5. And then South Central, and the TESO sub-regions. I've tried to highlight them on the screen, and we can see them. So I want to appreciate the facility, the districts, the regions, the facilities that have been able to achieve, despite the challenges we have in our national health system, but we are able to get at least the outstanding performance, 11 of them. And I think we shall get the details in the course of the day, who are these facilities. The star rating again is here. We can see it as the years have been progressing from 2021 to 2023. Over this period, the percentage of the facilities scoring star 0, you can see, has been reducing. I think we need also to appreciate this. Star 0 is the worst, the lowest. And number of facilities, there are quite a number that are scoring star 0. And we need to, the leadership and all the actors should see how we can really address and improve this. This is Rugarama General Hospital. It's a star 5 facility you can see in Kabale. We want to appreciate them. It's a PNFP. They are doing really good work, and you can see the facilities, the inside, the different areas, the OPD, the inpatient, the NICU, they are all really, they are reflecting the star 5 status. We have not done the validation, but I think we shall also do it at one point in time. So I want to thank the management, the staff of Rugarama Center, General Hospital, for the work, job well done. And you look at the walls, we don't want materials on the walls. I think I should also use the opportunity to say this. Yeah, we put everything you want to put on a notice board. I don't know, the SOPs, etc., they should be in the files and people can access them doing CME. So we want to really to appreciate this exemplary. Then Rushere, hope I got it correct. This is another PNFP, also scored star 5. So we we can clap for them really. Yes, it is not easy. And these are standards. We look for them, and they are the things that are happening. They are digitized. I think that was one of the key steps we found in the Health Center 4. They have digitized the services, and they are accessible and appreciated. This tool also assesses the client satisfaction. It's part of it. So also the community is also happy with what's being done. Then the big one, Lacho, could not miss the party. We need to thank the management. Can we clap for Lacho Hospital? They are here. They have already made a presentation. We want to thank them. They have a lot of patients, but also they keep quality alongside what's being done. And the big one from West Nile, Ajumani, is also part of the success story. And we want to thank them and also clap for them. They are the last one I think I'm sharing. The others will be known later on, I think, in the course of the day, because we are going to recognize them. It's not easy under the circumstances. You need people who can really, you look at the cleanliness, the tidiness, look at the walls. There's nothing on the wall. Look at the staff, smart, uniform, the name tag is there. You know, I think the staff file speaks for itself. And he even has a mask. So I think this is very credible. And look at the bed sheets. What is a private over within Ajumana? I don't know. But I think they are doing it right, really. Private within a public. But it's a public, I think it's important also to know this is a public facility. So things can happen. People are, yes. We say we lament, we say we don't have this, we don't have what. Some people can do it under the circumstances. And the staff must be smart and well dressed, and you're up for the job. So I want to appreciate. So what we need to accomplish, maybe, we need, this is a point of emphasis. We need to use this data. It is with you in one way or another. So we need to make sure it is disseminated. How do we disseminate it? Performance reviews now are happening in many regions. It's an opportunity. The regional CHI meetings with the learning session, CMEs. I think the opportunities we have really, CMEs in the facilities. Let this data be broken down, and the statisticians and the managers should take note. Do break it down. Don't give people the complicated details. But I think the areas of interest and the performance reviews are really great opportunities. Access rights is being worked on. This HHFA is now linked to the HMIS, the DHIS2. So you need access rights, and this is being really worked on expeditiously. The biostatisticians, health facility in charges, and regional teams should be on top of this. Don't wait for the Minister of Health to bring the data to you, but try to work within this resource, because it is very close to you at your place of work. Let us identify the gaps, most important. Most of the data sometimes is generalized, like I've shared now. So you need to sit down, I think, as a facility, as a region, and you see which gaps are there and how they can be addressed. And then capacity building, we need to continue, continuous capacity building, training, and people getting used to this assessment, which we are going to see more. If insurance is going to come tomorrow, the assessment will be even more predominant. Then, of course, the self-assessment, we need to emphasize this. Self-assessment, when it is done externally, the tool now is digitized, so you have it on your phone, and it should be having it done. You don't do it for the whole facility, but you can select areas where you can do the assessment. And for the private, where you are going to see that the ministers emphasize, and the PS top management, that we tie it with licensure. So as we move towards, I think, consolidating what we are doing with the private sector, I'm sure we are shall be able to bring this one forward. Supervision and the monitoring, all these elements can survive when you are doing monitoring and you're doing supervision. So all of us are supposed to be involved into this. Okay, the West Nile, let me go back to West Nile very briefly. I'm about to conclude the trends. I want to appreciate Avis. I know that Avis is here. Anybody from Avis? Yes, kindly clap for them. Yes, they have done a lot of good work in West Nile to make sure they continuously do the assessment and get the results and follow the trends and see how we can address the gaps. It's a bit of a crowded bar chart, but it's showing you progress from 20 as far as 2018 on your from your left side, I think, going towards the blue, from the orange, the blue, the progress that has been taking place in terms of performance, and it's been improvement all along, apart for all the districts, apart from I think very few. Many of them are scoring progressively well. So we need to keep up the momentum to see that the work done keeps yielding results. What are the factors? I'm sure you know them. Yes, factors that can enable us move forward. Leadership, it goes without saying. We need the leaders to be available, the leaders who are supportive, who are interested, the leaders who are chairing meetings. It's as simple as that. You coordinate, you get involved and participate. But if you miss the leadership, and leadership does not mean Minister of Health, it means all the way down to regional referral hospitals, the directors, the DHOs, the in-charges of facilities. But maybe most critical, our colleagues heading the units, the head of maternity, head of Those are the leaders we are talking about. They need to be interested, they need to be supportive, and getting involved in everything to do with this assessment. Then we need the partner support. I've already mentioned some of their more partners who have been involved. We want to thank them, all of them, for continuing supporting us. UNICEF and the AVIS, USAID Rights, the Baylor, and others have been extremely supportive. We want to thank them, and we want to again appeal to them and others to continue prioritizing this assessment. It will help us. You know, there's not one. Yesterday, the other day, we learned that you cannot address the issues of health service delivery by focusing on one area, by increasing the salaries, and you stop there. No, you also need to look at other critical areas. So the assessment of implementation of service standards is extremely important, and we want it to be prioritized. Then we needed to, as I talked about, the capacity to generate and use the data. We are going to really give it a lot of focus. When we call upon you in data collection, participate. The analysis, we don't want the Minister of Health to do analysis or the partner to do the analysis for us. Let us do it ourselves and also generate reports. That will make it easier for us to appreciate what is positive and where are the gaps. The data managers, you are the key people we need. I know many of them are not here. Kindly take the message to them. From the Community Health Department, I'm about to conclude. I've been told the time is running out. Data managers, please put them at task to do the analysis and give us simplified reports that make sense for decision making. The DHT, you have the statisticians who are there, then they do proper analysis and identifying the gaps. Monitoring, I've talked about the monitoring already. Demand-driven, you want demand-driven and focused supervision. Performance reviews and CMEs can be used to really bring out elements that people need to know, and also come have the indicators that we need. Regular supervision, I've mentioned that one already. And I hope you can see the define and adopt HHFA standards. We need to know the standards. People, they don't know the standards. And the more are coming from different corners. HHFA is broad and standard. Kindly let us know them. So we should find time really to share these ones. And next steps, as I'm now concluding, we want regular implementation of this. I've talked about this already, but we prioritize HHFA and squeeze. Don't forget the squeeze. Squeeze, I think, in the next conference, they need to be here and tell a story, so that people, they know what's happening and how it's being useful. The cost is a challenge. I will also talk about it briefly. The cost, the harmonization of tools. Many assessments are taking place. Many tools are coming up. We kindly emphasize that we use the HHFA tool as the standard one. The others can be used for a defined purpose, and those involved should know that. Then using existing structures, also very important. The structures we have in our system. We are now talking about the performance reviews at all levels. It's not only at the regional referral, but at the district and in the facilities, especially facilities. Very few facilities have quarterly reviews. We need to bring out this culture, and so how we can bring out improve the utilization of this data. Best practice should be shared. As I think that is, a given. The cost is big. We have to also be mindful of this. The cost of big. This is from AVIS, what was being done. So what we need to do, I think, to institutionalize some of the activities we undertake, like data analysis and report writing, and some others, and they make the cost maybe cut on the cost, and also dealing with the high volume facilities first, within the resources available can be another area of consideration. Chair, allow me to appreciate all our partners. I've already mentioned this. All the region 4 hospitals, many of them have embraced this, and especially with the community health departments, the districts, the ministers, my colleagues are here, the SCAP. We are working, I think we're trying our best to see that HFPP is available and is realized in the national health system. And you're working closely with ICT, the planning department, and the health informatics and the technology division. So we appreciate everybody, the facilities and the community-based actors. I want to thank you so much for listening.
Thank you very much, Martin. Can we give him a loud applause once more? And also for those facilities that scored *5. And finally, for those who tried also. We know this is opportunity for improvement. Ladies and gentlemen, we are really, time is not on our side. This is supposed to be the time for discussions, yet we still have another presentation, so without wasting time, I would like to invite Professor Tumwine James of Kabale University to make his presentation, which is going to be online. Professor, you're welcome. Please, IT team, help him and us and make sure we are able to see the slides. Thank you so much.
This enabling environment for granted, from Kisoro up to Arua, up to Kitgum. I want to thank the Ministry of Health for provision of policy and helicopter view, leadership, and excellent stewardship. I want also to thank the organizers and partners who supported this important workshop. I want to thank you, colleagues, the community members, and others who have dedicated themselves to enhancement of service delivery, all protocol observed. I would like to start with this excellent leadership, particularly in quality improvement. And this manual must be a read for everybody. I don't know how available it is to the lower health units. And if it's not available, I would suggest that we make it available. I found it excellent read, and I want to congratulate the department, Dr. Senius and others for this very good work. So, what is a medical error? A medical error is
Professor, Professor, we request you to go on a slide view. Put slide view so that we can see very well. Thank you.
Okay. Let's try and do that. See the slide view now? Yeah. So a medical error is an act of omission or commission in the planning or implementation that contributes or might contribute to an unintended health outcome. And what I will do in the next few minutes is to give you an overview from the literature of the burden of medical errors in some areas in Uganda. And I have not done this research, it has been done by a number of people, and I've got it from the literature. I have summarized these results in the next few slides. Mauti in 2019 with Dr. Chiguba looked at 2 hospitals in Entebbe, Kisubi Hospital, which is a PNFP, and the General Hospital at Entebbe, the government hospital. And approximately 53, we had a percentage of 53% medical errors. Abigaba in 2021 in Mbarara Regional Referral Hospital found a prevalence of 43%. And in 2019, and I couldn't believe it, in her study for her degree at Makerere, Waduro found 100% medical errors in a rural general hospital, rural referral hospital. That gives you a general overview of those 3 studies. The studies of medical errors are really very few, and I don't know why that is the case. But often people fear to report medical errors, and we have to be extremely careful because people who commit errors don't want to be pointed out, but also usually the attitude of health workers is to blame the person who has made a medical error, and therefore there's a lot of fear. And of course, there's also fear of litigation. I hope you know that the number of universities offering the LLB degree have increased tremendously. And the LDC had one center in Kampala. Now they have 3 centers in Uganda. This is where the trained lawyers who have graduated. So there is a center in Kampala, there's a center in Mbarara, and there's a center in Lira. And they have almost 600 students in each of those centers. So if we are passing out almost 2,000 lawyers a year, hey, we have to be careful. We have to be careful because litigation is going to come.
if you look at the details of the Arua study, the commonest problem in terms of medical errors was administration of medicine. Apologies for that misspelling. Administration of the medicine. The second commonest error was dispensing of the medicine. And the next one was prescription challenges. So there we learned that the administration of the medicine was a problem. And there are many reasons for that, which I'm not going to go into. In Mbarara, the study was done at the cancer unit. And 37 patients, or rather 37% of the challenges had prescription errors, and the administration wasn't a big problem. So the problem was really prescription. And that to me was surprising, because this is a teaching hospital with specialists on the ward, and it was very surprising that prescription errors were very common. I would like now to talk briefly about errors of commission, where somebody takes an action, an intended action, and I'll give you examples. This is a child referred to us by a neighboring district, from a neighboring district, from a health center 4, or rather 3. And this child really suffered because the health worker was trying to treat dehydration with an intravenous drip. And the person did not know that the veins drain from the hands towards the elbow and towards the heart. She had put that drip in the opposite side. And you can see what happened. The arm basically was almost lost. And that is a picture that I took on admission of this child. Fortunately, the surgeons were quick and saved that limb. And here, I think there are really 2 critical issues. One is the lack of knowledge. This health worker has no knowledge of anatomy, absolutely no knowledge of anatomy, and was not really trained adequately to know the basic anatomy of veins and where the blood flows. But this is very disturbing, because, you know, William Harvey is the one who demonstrated how veins drain. And this is learned in biology. And of course, lack of skills was also another issue, I think. A lot of people are trained on dummies. There's a craze about skills labs. People are injecting oranges, yet we have over 45 million people on which we can give injections. We are picking Western ways of training without thinking about them. And I think this is a big, big challenge. This is also, picture is very painful for me, because it is an error, again, of commission. This patient had fever and cough for 4 days and was seen at Health Center 3. The child also had refused to breastfeed for 3 days. And we teach all our students, like I was taught, that when a child refuses to breastfeed, that is bad news. That is pyogenic meningitis until proved otherwise. The health worker at this place gave amoxicillin. A child who has refused to breastfeed and has meningitis was given amoxicillin. And of course, the patient did not improve. The patient was also given cough mixture. And as it turned out, the patient was referred to us with hydrocephalus, secondary to the meningitis. So we have a long challenge. We have a big challenge on our hands of making sure that people are properly trained. They are given the knowledge and the skills. I will share this slide. I've shared it with some of you before. This patient had cough, several bouts of cough. Like all of us see children these days. Brian goes to nursery, is in a upper class or middle class, and picks a common cold from there. And everybody at home gets that cold, including some of you who are parents. But for you, cough is not a problem. Cough is a problem for this child, especially when you have ignorant people managing that cough. So the mother goes now to the pharmacy, and without prescription, without thinking, the person running the pharmacy gives this child dexamethasone. And this is a prescription drug. Dexamethasone is a prescription drug. But you can buy it over the counter anywhere in the pharmacy. So I appeal for my pharmacy friends. Please help us. Let's not give corticosteroids over the counter. Anyway, this patient, you can see the obesity. And as it turned out, this patient has Cushing's syndrome. Dexamethasone is not matoke. It is steroid, and we should not be giving it to patients lightly. So please leave our children alone. I'm talking now as a pediatrician. Don't just give our children anything. First make a diagnosis and then give the appropriate treatment. But as it turns out, anybody is giving corticosteroid. Several years back, many years back, I did a World Bank consultancy. And to cut a long story short, we were in Fort Port in Kabarole, near a place called Kisomoro. And we visited a drug shop, and it was being run by an S4 dropout who has never stepped in any training institution. And that pharmacy, that drug shop was selling prednisolone, which is a steroid. So we have a big, big issue on our hands. The education of our people to shun these places where we have no trained individuals selling medicine. This is an era of omission. I want to tell you about this child. This child is IK. He was a 7-year-old boy, and I treated him for tuberculous meningitis, and he made remarkable improvement. He had been extremely sick, deeply unconscious, and he woke up. Unfortunately, he developed pressure sores and subsequently got septicemia and died. What was the omission? There was no appropriate nursing care to prevent pressure sores. And of course, once you have sores, there's no skin to protect you. So the bacteria will enter through these sores, and this is how IK died. Every week, the father calls me and we have a chat. I have not recovered in the last 6 months from the pain of losing IK. So if you are a nurse, if you are a doctor, if you have any other health worker, remember these nursing sores are deadly and their prevention is very, very simple. And it's beyond the scope of my talk. Areas of omission, we need to focus our attention in these priority areas that I've mentioned. What innovations have we carried out to minimize medical errors in Uganda? Let's keep it simple. In my view, the most important intervention in preventing medical errors is training. Training, training, training. And that means we are creating competent health workers. And in simple language, if you are going to be competent, you need knowledge, you need skills, and you need good attitude. I'll just talk about the training that I carry out. And I hope that people can start training people like that. Our training involves day-to-day care of patients. You cannot train a mechanic without a garage. And the mechanic must be in the garage every single day, working on the cars. Now there's a craze of learning online. If you are learning online, how do you learn how to repair an engine? You cannot be a good mechanic unless you are repairing real cars. And this is my plea. We cannot train good health workers unless we train them in the garage. And that garage is our health center. That garage is our hospital bed. That garage is the community. So we spend our time caring for patients and their families, and we do that as inpatients. We train our health workers how to handle emergencies, and we also train them how to give ambulatory care in the community. Let me repeat, we emphasize knowledge, skills, and good attitude. And I'm so glad that our president emphasizes skilling Uganda. A country without skills is doomed. And it's good that now we have a curriculum in the secondary school, which we've been campaigning for, that is competence-based. And I think that's where all of us have to move. I love this picture because some of you might see yourselves in that picture. So clinical training must be at the center stage, above everything else. If you don't have very well clinically trained people, then who will look after our population? Let me give you an example. This is a slide that is painful for me. A long time ago, when I was working in Mulago, we had a patient who had been attending the sickle cell clinic for several years. And you could see on the left side of the picture, the first hand there had spindle-shaped fingers. And this patient also had recurrent fever and joint pains and was attending the sickle cell clinic, and nobody had bothered to do the hemoglobin electrophoresis. And the patient, therefore, was being treated for sickle cell disease. As it turned out, this patient had juvenile rheumatoid arthritis, which can present almost in the same way as sickle cell disease. You don't believe it, but it is true. And to me, a good history, detailed, appropriate physical examination, and looking at a peripheral blood smear would have settled the diagnosis. And really, in this day and age, for a patient of rheumatoid arthritis to be every month visiting the sickle cell clinic is big shame. And the way we are going to do it, yes, you are right, is to train and train and train and train. There's an issue, and this issue I think was talked about by my friend, Peter Weisel. We all know from the statistics that we share, that the ministry shares, and we are so grateful for these statistics, that problems of the newborn, the perinatal problems, are the leading challenges in this country. They are the main area where we see a lot of deaths and a lot of morbidity, and they are challenging us. And one of the reasons is that we have not emphasized care of the newborn. A lot of emphasis remains on cesarean section. But remember, when you do a cesarean section, it's not for the sake of it or saving the mother. You are producing a new Ugandan, and many people forget that. In this particular slide, which I took in Burkina Faso, in a place called Bobo Dioulasso, look at this child. The child has come out. The mother has got soil in her hands and her legs, and nobody bothered to cover the feet. So the mother got tetanus, and the child, of course, had neonatal sepsis. And in Luganda, we say, nebigendelako. We have to emphasize helping babies to breathe. If we lose that one golden minute and the baby does not breathe, we have serious consequences. The child can die. The child can get brain problems. The brain can be damaged. Unfortunately, and I think I'm speaking what all of you know, a child is born with an APGAR score of 2. And because of fear of blame, or there is some muzimu, what is muzimu? There's some ghost which has invaded our midwives. The APGAR score is 2, and they put APGAR score of 7. To me, if you are a liar, you are corrupt. If you say the APGAR score is 7 when it is actually 2, you are very corrupt. So we need to train our health workers to be honest. If the APGAR score is 2, it is 2. And we are not going to blame the midwife that the APGAR score was 2. let me repeat. Minimize medical errors. We need competent health workers. And the health workers must have knowledge. They must be skilled. But above all, they must have good attitude. You could have a PhD in obstetrics or in pediatrics or in public health, but your PhD is absolutely useless if you have poor attitude. You have a severely anemic patient and you know how to manage, you know how to give the transfusion, you know how to put on the drip, and you are first asking the parents, you're asking actually the nurses who are helping you. This little Josephine, we have to transfuse. But Basasode, have they got some have got the money? And this sounds ridiculous. But our patients are being faced not with indirect payment, but you have a child with hydrocephalus whom we want to be attended. And the patients are told openly, we need 5 million to operate on your child. So is that corruption or is it medical error? I don't know, I get confused. And I've been sending my patients to Cure Children's Hospital in Mbale. Imagine, I'm 400 kilometers away from Kampala. So from Kabale to Kampala is 400. From Kampala to Mbale is 230. So my patients are going 632 kilometers to look for a place where they can put a shunt to drain the cerebrospinal fluid. That child I showed you was kindly treated by Cure Hospital. In my view, they are the heroes. And I hope, sir, you can include Cure Hospital among the heroic hospitals in our country. And we need critically now, in my view, as a Minister of Health, to review the charges that our disease policies are asking our patients to pay. If I have hydrocephalus, was it my fault? So why do you need 5 million from me to insert a shunt? So, Chair, what remains to be done? In my view, we need to go to the parish. And our government has gone to the parish with parish development model. We must use that opportunity for community engagement. Professor Maswa used to tell us, health begins at home. And I agree with him 100%. The political organization now is focused at the parish level. We must take that opportunity to sensitize our people about their own health, but particularly about minimizing medical errors. Secondly, we need community and other stakeholder engagement, and we need to strengthen support supervision. I'll show you a couple of slides and stop. In this slide, our Department of Pediatrics and Child Health at Kabale organized a stakeholder meeting. And I know my friend and boss, Philbert Nyeko, you are listening to me. So I'm sure you're enjoying seeing your face there. But on a more serious note, this particular meeting brought together all the stakeholders, the nurses, the doctors, the district health officer, etc., to deliberate, to think about the future of training of pediatrics in our School of Medicine. Finally, support supervision. support supervision. Many of our health centers, Health Center 4, Health Center 3, they are run by our heroes, our very hardworking nurses, doctors, and environmental health people. We need to give them regular support supervision. And in this picture, I proudly put it there. I am posing with the management and the staff of Nyachibale Hospital, which is in Rukunjiri. It is it's almost over 80 kilometers away, but we were able to go regularly and support this hospital and critically look at the care of children and others, including the importance of minimizing medical errors. So, Chair, what have I said? I've thanked you. I've had an introduction. I've talked about what are medical errors, their status in Uganda, and our innovations to tackle medical errors, and what remains to be done. Thank you very much indeed. I'm done, sir.
Yes, thank you so much, Professor. That is typical of you when you taught us when we were students. We have learned so much from you today. Indeed, this was a keynote address to prevent errors, medical errors, and therefore to maintain patient safety when we manage them. Thank you so much. I would like to invite the members to clap for you. Thank you, thank you. So, members, we are really not doing well regarding time. I would like to invite Dr. Martin Sentiona in front. We shall have brief questions for Dr. Martin Sentiona and Professor Tumwine. Please, Professor, remain online. We are going to have a few questions and remarks from the members here. So, Dr. Sentiona, come in front. We are going to take a few questions in order to comply with the time. I know we are already late, but nevertheless, we need to have a few questions and remarks. So I would like to invite people who have questions. I want to request that somebody moves around with the microphone. Do we have one? And those who want to ask questions, put up your hands, and we shall have only one set of questions. From this side, there is one there. Let's start with that one. Then here, this one, that, there are quite many. That one, about. Okay, some questions will be already online. They will also be projected. So can we have the questions?
And thank you very much for this section today. Good morning, everyone. And I would like to take this opportunity to thank Professor Tumwine for such a wonderful presentation, which is typical of our country and what is happening within our community. I have a few comments I would like to make and question. Professor has emphasized training, and has mentioned about the primary health caregivers within our communities. But before these health care workers reach our communities, they first got training schools. And we are seeing training schools coming up almost every day, irrespective of government communications on regulations of training. And we would like to ask ourselves, who opens up these training schools, major nursing training schools and clinical officer training schools every day, okay, with very less supervision? And who trains these students? Because the skills we are seeing in our community, they don't show training. So who trains these people who come to treat our parents, our sisters, our mothers who are delivering, who trains them. So as they come to our communities with no skills, we don't see skills in them. And then lastly, the infrastructure versus the numbers of students admitted vis-a-vis their performance. We have seen very poor performances of students at Senior 4 and Senior 6, but surprisingly, you are going to find these students admitted in healthcare training institutions. You can move around the country, you will find people admitted with no results for science courses. So these health training institutions still have very low facilities.
Point noted. Try to give some time for others.
Thank you very much.
And for those who are going to ask, please just hit the question and then give time for the others. Otherwise, we will only remain with your question and others will not ask. Next.
Thank you very much, Professor, for that elaborate presentation. My name is Akinobe Lydia, and I'm from Mengo Hospital. My question is that, who recruits such kind of people that come to work without skills? How are they recruited? And where did the supervision end? Because if there are students that are making such kind of errors, they should be supervised. They should be working under seniors. And who follows up with this supervision? After all those errors, what happened? Thank you.
Thank you so much. Next.
Thank you, Chair.
You can forfeit applauding, thanking, introducing. Quickly go to your question.
Okay, my name is Moses Valina from Maldima, Uganda, and my question goes to Professor Tumwine. Prof, I'll start with the point where you were on support supervision in Kabarole district, and you found an S4 dropout running a drug shop selling prednisone. I want to escalate this to a pharmacy. The Ministry of Health has now started implementing the community retail pharmacy drug distribution point. And in here, they have added in many services, including TB screening, TB management. Would you recommend that for every pharmacy that is participating in this DSD model should have a clinician recruited? Thank you very much.
Thank you. Next. Where is the microphone?
Thank
Please
you.
there.
Thank you, Session Chair. My name is Gilbert from Blissa District. From the presentation or the keynote address by this professor, I want to say that for the health systems to perform, there must be strict and well-informed monitoring. And I think from experience, when you look at the monitors in the systems of government setup, the monitors ordinarily are supposed to be knowing what the person they are to monitor are supposed to be doing. But many times when you look at, for example, the monitors who are supposed to ensure effective performance of health systems, they themselves do not actually know what the person to be monitored is supposed to be knowing. And the design, for example, in the case of health center force, general hospitals in districts, these are actually the political leaders. Now, when you look at the design further, in the Local Government Act,
what is your question?
The question is, what can be a solution in a situation where the monitors do not know what to monitor?
Okay,
that is because that is the challenge.
All right, point taken. Next.
Thank you, Chair. I'm Bernard Ayebazibwe, USAID Uganda Health Activity Chigezi. My question goes to Dr. Martin. Thank you for the overview of the HHFA. In terms of the access, you mentioned that the district biostatisticians already have the access, but my appeal is that we need wider access to the HHFA database so that we can able to use this information to further effect improvements across board. So the request is that we have a good number of the IP staff as well have access rights to the HHFA database so that it can form further improvements. Thank you.
Thank you.
Thank you very much. My question.
Who is that? Who is asking?
I'm Philip Mhamia.
I think that could be the last one.
Yes, I work with the local governments, and the challenge has been recruiting health workers in these local governments. Yes, there is the decentralization of the service commission in the districts. Could there be an involvement of the Ministry of Health, especially when we are recruiting these health workers, like the regional fire hospitals? Can there be a representative, a technical representative from the Ministry of Health when recruiting these health workers? Because recruitments are, I should say, they are biased in local governments.
Thank you. Now we go to the questions that are online. IT, please, can you show us the questions online so that we go through them and then they're answered at once? I'm sorry for those who have not asked. You could, maybe you know the presenters, you could contact them and be able to share your concerns. One question is from Peterson Kamugisha. He says, thank you, Professor. Kindly give your opinion about the quality of training in relation to the number of students versus the size of practicum sites. Another one is from Samuel Okiror. What are the medical errors in relation to laboratory department? Second question, what's your take on especially the wrong prescription by private facilities on medical insurance schemes? Is there any other question online? Those are all, okay, there's this one. Thank you, Professor Tumuine, for the passionate keynote address. What recommendations would you make for the government towards regulation of training institutions for delivery delivery of competent healthcare workers? Okay, so thank you so much. So we are going for answers. I think most of the questions went to Professor Tumuine. Professor, if you're online, kindly respond to some of these questions. Then I will ask Dr. Martin to respond to the rest. Thank you so much.
Somebody has not qualified to go to a training institution and yet is admitted there. I think the critical areas. One is, I use a Luganda word, which is used when they are campaigning accidents. They say, twedeko. Let us do some introspection first. So if you are running a health institution, there are basic qualifications. I'll just give an example of medicine because I'm in charge of medical training here. For us, as a rule, to be admitted to our medical school, you need a minimum of C in biology and C in chemistry. And we don't care who you are, where you are from, how much money you have. If you don't have a minimum C in biology, a minimum C in chemistry, we do not welcome you to our medical school. And we tell them, you can go elsewhere where they take lower qualifications. But that's not good for us. We need, at a higher level, the different regulatory bodies to become tough and inspect the training institutions that are admitting poorly qualified people. The second question was availability of supervisors. people who are listening to me, let us be honest. We know that in almost every health unit, from the health center to the regional referral hospital, people do not come to work. You are supposed to work 22 days in a month, and some people are spending 3 days in a month. So if you are a supervisor and you are coming 3 days in a month, you are supervising interns, you are supervising nurses, who will then supervise? And the Ministry of Health, I really pity them, because you are the ones now having such people. They have big salaries, but somebody coming even 8 days a week, a month, is not good enough. Somebody should come for the 22 days. So I think the ministry has already started tightening, and I really applaud you. We must work. If people don't want to work, let them resign. Now, the pharmacy. Should we have a clinician at the pharmacy? My answer is no. The pharmacists should know their job. And their job is, when there is a prescription, they should give the medicine. And without offending anybody, some people now, they want even to prescribe medicine. You have never been trained how to diagnose, and you want to prescribe. I prescribe ceftriaxone, you say, now, but you know, this amoxicillin can also work. What Professor wrote is very expensive. Who are you? You've never been trained in pediatrics, and you are shutting down my prescription. So I think we need to work with the Pharmacy Council, the NDA, and also all of us as health workers. We should respect one another. We stick to our areas and avoid doing things which we don't know. Then there's the issue, sir, of strict, well-informed monitors who must know what they are doing. Yes, obviously. If you don't know how to drive, how can you supervise drivers? So we need one to make sure that the monitoring team has a technical person, but also we need to empower the people who are on that team, whether they are counselors or etc. We give them basic training. A lot of the things we do is not rocket science. As you have seen in my presentation, I made sure there were no genomes, there were no complicated things. So we need to learn to be simple and empower our monitors. Who does the training in the training schools? Well, we have a mushroom of training schools, and we know that we do not have enough tutors. So it's possible that training schools do not have qualified trainers, but that's not my area. I think we should also emphasize the village health team. I worked in Zimbabwe, and I was setting up their system in the eastern part of Zimbabwe. And we trained our village health team members, and we empowered them how to recognize different problems. So I think we need to empower our village health team members. The entry qualifications, I think that was the last one. No, there was the errors, the lab errors. I didn't talk about errors, lab errors. There wouldn't have been time. And the massive prescription for health insurance. We need again to work with the companies and the private units to say that usually patients who need more than 4 medicines, we call that polypharmacy. We need to sensitize even the people in the health sector who are working for money, that you don't need to do the wrong thing to make money. And also the insurance companies can tighten up and refuse to pay for too much medicine. Thank you very much, Chair.
Respond to those which are made towards him.
Thank you. Thank you very much, Chair. I want to appreciate. I received one question. Allow me, Chief, before I respond to that, to inform the audience here that we have a patient safety project running in the ministry. JICA is giving us a lot of support. And God willing, I think in the next conference, they should be able to come and share the story, and we learn more from what's happening and how we can improve. On sharing the access rights, as I mentioned, this has been done largely to the district biostatisticians and the contact persons, the regional fire hospitals responsible for data management. So if we need to involve more, I think it can be considered. We shall discuss this internally and see how we can involve other actors. But data has to be protected, so we shall see how the best way to do this, and we improve access to the access right. Thank you.
Thank you so much. That has been the morning plenary session. I had Dr. Martin Sentiona and Professor Tumuine. They have presented, and we have asked questions, and they have ably answered. I've been Dr. Alex Andema, the chairperson for this session. I would like to hand over to the organizers. Thank you so much.
Thank you, Dr. Alex. Colleagues, another big hand of applause to the presenters. Let's also appreciate our presenters, Dr. Martin and Professor Tumuine, for the wonderful presentations. We are running a bit late, but we had to give this subject time. As you can see, the issues are engaging. But we call upon you, those who have not been able to raise the questions. We have the secretariat desk there. You can kindly note an issue and pass it on to them. If we get time during the day, we shall find an opportunity on how this can be addressed, and we get feedback to you. We are going to have a health break, and we request that we utilize at least 15 minutes. And if we refer to our conference book, after the health break, we are going to be having our breakout sessions. We are having 2 sessions, as we have been doing, one here in Ziba Hall, but also in Kama Hall. But we would want to encourage you, some of you who have been seated here for 2 days, please don't go without visiting Kama Hall. There are good things up there also. I know you may feel uncomfortable to climb the stairs, but it's part of the reasons why you are here, to learn from different avenues. So we expect to see the numbers increase in Kama Hall for the presentations. And each of those will be having 9 presentations, and the chairs will be waiting for you once we open up. The one in Kama Hall will be chaired by Dr. Philbert Nyeko, and the one here in Ziba will be chaired by Dr. Wangisi Jonathan. So let's move out for break tea, and we give it 15 minutes, and we can now separate into those respective breakout sessions. Thank you, and please, let's keep time. Okay, good morning once again. Colleagues, as you pick tea, we request that you will quickly pick our cup of tea, and this becomes a working session. We shall have a working tea to try and catch up with time. We have 9 presentations that are lined up for us, which we are supposed to cover before we break off for lunch at 1:30. So let's observe time. The presenters who are supposed to be in Ziba, we request you to come in the hall and prepare. And those who are supposed to be going to Kama Hall, Dr. Bukenya has already proceeded and we are waiting for you. Let's pick our tea and we come back to the hall so that we move. We have 9 sessions of presentations, and remember we have to hear from these people as well as discuss what they have shared. So we may not exhaustively do that if we don't give them time. The chair for Kama Hall is Dr. Nyeko Filbert. So in Kama Hall, Dr. Nyeko Filbert will be leading the sessions that side, and they are waiting for you to start. Remember, we mentioned once again that in case you have joined us today, we have 2 halls for the breakout session. So for this session that we are going to go into, the abstracts and presentations, feel free to choose any of them. And to be specific, the group of people that are staying here, we are going to be looking at abstracts that focus on medicines and suppliers management and health management information system. So medicine supplies and health management systems, we are here in Ziba. But in Kama Hall, should you be interested in improved service delivery models and health infrastructure, then you can proceed to the other hall. You just follow the corridor out there and you'll be guided. So if your interest is in the service delivery, community models and infrastructure, you can proceed to Kama. For Ziba here, we are going to be looking at medicine, supplies management, and also health information management system. So I would like to call upon Dr. Wangisi Jonathan from Mbale District Local Government to kindly step forward and lead the sessions that are going to be in this hall, and he will continue to provide more guidance together with calling the presenters that are supposed to be here as we proceed. Kindly observe time as guided by the chair. We request to have at least be through by all this by 1:30 so that we can have our lunch on time. You can give him a welcome clap as he comes to take over this session. Welcome, Doctor.
Yeah, thank you so much, Master of Ceremonies. Good morning, friends. My name's Dr. Jonathan Wangisi. I'm the District Health Officer from Mbale District Local Government. It's an honor and privilege for me to be standing before you and moderate the next breakout session in this hall. We are in Ziba Hall, and like it has rightly been pointed out, we are going to be looking at medicines and health supplies management and the health management information systems. We have a series of presentations, to be exact there are 9, and friends, our session was supposed to have begun at 10:30. If you look at the program, it is now, we're almost 1 hour behind. It's 11:23. And I know all of us are planning and strategizing to find a way of leaving this place earlier and maybe connecting to our various destinations. So we are going to keep time and cruise a little faster. I just want to give a small preamble as the people settle down. Those going to Kama, please, Kama is the other side. But I just wanted to say as a preamble that whereas we have come here to talk about quality improvement, and you heard from Professor, our teacher, that we have issues with the quality, but you cannot have quality healthcare if you don't have medicines and other health supplies being available, and that is going to be at the heart of our conversation. We know that the Ministry of Health has continued to ensure that health commodities are continuously managed, tracked, and reported. Even our DHIS2 system and other national reporting systems do that ably. We shall remember that about 13 years ago, we, Ministry again with our health development partners, introduced the SPAs, the supervision, performance assessment, and recognition strategy. As the local governments, we believe it has tried to help us. It was a multi-pronged intervention strategy for strengthening medicines management in Uganda, targeting both government and PNFP facilities. Later on, we got to have the lab SPAs joining the medicine SPAs, and they work together to ensure that our medicines and other commodities are better managed. You remember that the SPAs is based on a spider graph or 5 domains of reporting, ordering and reporting, storage, management, stock management, prescription, and dispensing qualities. So I think when you look through the program, we shall be partaking of that a little bit. But I just wanted to end with this. 2 days ago, while I was seated in here, we received a mail as local governments from the head of supply chain of Ministry of Health. And that mail was a bit disturbing. It was giving us key highlights of January 2024 as regards the supply chain report. And it was talking about, he said about 74% of our facilities are doing complete reporting of supply chain data into the DHIS2. But ladies and gentlemen, what struck me was the fact that 43 of these facilities were overstocked with first-line antimalarials, SCTs, while 14% were stocked out. And we've been running these SPAs. So I think I hope this conversation will lead us to something. And the other intriguing fact was that some facilities in Nabila-Tuku and Wakiso had 18,000 months of stock of Depo-Provera. 18,000 months. I tried to compute, that is 1,500 years of stock, or 150 decades of stock. So you can imagine that stock, if nothing is done about it, we shall disappear from this universe, and maybe the next 10 generations where stock is in that facility, if nothing is done. So I think it calls that as we go into the presentation, we'll look at what Ministry of Health, the regional partners, and us, the district health teams and the regional teams, what are we doing to make this a better situation. So without wasting much additional time, I want to call upon the just roll call, and then we get started. Our first presentation will be on using the reproductive health SPAs to strengthen reproductive health commodities, commodity management in a low-income urban setting, lessons from Kampala, City, Uganda, and it will be presented by Martin Cassandra. Martin, I don't know whether Martin is around. Martin, please step forward. We are getting started. We don't have any additional time. Martin, step forward, I beg your pardon, and you take up your seat. The next presentation, I hope IT or loading, will be on, that is now on stock management. We shall hear something about stock management. The second presentation will be on improving rational prescribing or prescription among clinicians in Mother Francisca Lechner Health Center 4 in Rushoka, and it will be done by Muhwezi Aaron. I don't know, Aaron, please just move a little in front here. I don't want to waste time moving from there. Just step forward. I would have loved even to bring you this side, but you'll come over as you present. The third presentation, ladies and gentlemen, will be on leveraging WhatsApp to enhance timeliness of orders in Buhweju district health facilities, and to be done by Mohamia Philip. Philip, please do the needful. I want to have my presenters in front so that we can cruise. Please just accept to be inconvenienced and we assemble. The fourth presentation, ladies and gentlemen, will be on data-driven malaria commodity management, addressing discrepancies, ensuring accountability, and realizing billions in savings through political engagement in the Busoga region, and to be done by Patricia. Patricia, thank you. Thank you, Patricia. And then the fifth presentation will be on increasing the proportion of HIV positive women screened for cervical cancer at Rukunyu Hospital, and to be done by none other than Ruth Tivingamba. Is Ruth there? Okay. Please step forward. Our sixth presentation, ladies and gentlemen, will be on a HMIS approach to improving maternal and child health service delivery, application of a maternal and neonatal obstetric complication survey tool in Rakai and Chotera, and to be done by Richard Kimaka. I think that is Richard. Thank you. Our seventh presentation will be on scaling up the implementation of social network strategy. Improves HIV case identification by Kasakaire Joel. Is Kasakaire Joel here, or a representative? Please, you better. So if he's coming later, I think he will be the last to present. We shall need to. Then eighth, relying on technological innovation for quality improvement in Chigezi region by Didas Rutunje. Didas, please step forward. Thank you. Didas is here. And last but not least, ladies and gentlemen, our last presentation will be on influence of national-led mentorships in improving the performance of quality improvement collaboratives. Learning from DREAMS collaborative in CDC-supported regions. And that will be done by Simba Wilfred. Thank you. So, ladies and gentlemen, we are good to go. I'm going to ask our presenters 10 minutes. If you can spare us and do 5, 6, we shall clap for even harder. So without much further ado, ladies and gentlemen, please, let's put our hands together and we invite our first presenter, Martin, to share with us. Let's put our hands together and welcome Martin. Martin, 10 minutes, please. When you're done, you join me at the podium.
Good morning to you all. My name is Martin Kasendwa. I'm the Program Implementation Manager for Kampala for the USAID-funded Maternal Child Health and Nutrition activity implemented by FHI 360 as the lead partner. So I'm here today to present on strengthening, on using the reproductive health supervision performance assessment and recognition strategy to strengthen reproductive health commodity management in Kampala. Next. Okay. So this slide gives us a preamble of what Kampala is like. We have a population of 1.7 million residents, but I know many of you who come to Kampala during the day come from the nearby districts. So the nighttime population is 1.7 million, but daytime we have 4.5 million people. And unemployment rate is high, at 21%, highest in the country. 60% of the resident population reside in slums. We have 60 slums in the city. The most interesting thing is we have 2,287 health facilities in the city, and only 1.2 are public, 1.2% of the 2,000. The rest are private for profit and private not for profit. So we have a big private sector presence in the city. So the issue at hand, Kampala has a very high population growth rate, seen at 4.03%. And there's need to optimize this growing population with accelerated economic growth if we are to realize the demographic dividend, because the government of Uganda's 2040 vision highlights reducing the country's population as one of the key factors we need to address if we are to reap the demographic dividend, which refers to balancing population growth with accelerated economic growth. To achieve the demographic dividend, we need to do a number of things. We need to see that we decrease the birth and death rates, and also improve the education systems to reduce the dependency ratio. With fewer children in the household, there will be more investment in the few children we have, more freedom for women to participate in the national labor market, more household savings, which can be then channeled into economic development for the country. So given that we need this, we need for us to achieve the fewer children, we need to scale up access to contraceptives among the measures. So what did we do? We used the hub and spoke model. We have the Kawempe National Referral Hospital, which we work with closely together with Chirudu and Naguru. And what we are trying to do is to make the pharmacists at these hospitals building their capacity to provide technical assistance to the lower level health facility. We've worked with them together with the KCCA medicines management supervisors. SPAs cannot work alone. We need a holistic approach. So previously, SPAs visits were conducted alone. We have the family planning teams also doing their separate visits. By this time, we made sure that there's a team approach. You have the medicine management supervisors moving to the facilities together with the family planning mentors to provide holistic mentorship. So we have family planning SPAs happening together with the CQI collaborative coaching. We use the Pareto analysis model to prioritize the facilities to go to. Like you've seen, we have 2,000 facilities. You can't go everywhere. So we realized that 80% of the family planning services in Kampala are given by 35 health facilities. Out of the 2,000, only 35 give 80%. So we first focused on those. And the learnings from these are going to be cascaded to the other facilities. One of the key things we found was that the family planning work improvement teams did not have records, and they also did not have the facility medicines management teams embedded. So they were incomplete WIDs. So we made sure that we support the facilities to select work improvement team members in line with the processes for family planning service delivery, including data management and commodity management. Every time the cycles are filled, we support KCCA to conduct order field analysis and engage NMS or JMS where they have undersupplied, so that they either do back orders or they do emergency orders to fill the gaps, which has been a common case for all the regions in the previous 1 year. We also support KCCA to do stock monitoring. I know the people in HIV, you have real-time stock status monitoring, not so? This is something we've taken up in the family health side as well, where we support the districts to do family planning, commodity stock monitoring. Another important thing we've done is strengthen KCCA's stewardship. Every month, KCCA invites supply chain stakeholders in the city to conduct supply chain review meetings, review order fill rates, stock available, and also track actions from the previous meetings. So we've had improvement across the 4 domains of the reproductive health PAS tool. One is clinical quality, which looks at prescribing quality, documentation, availability of HMIS tools, availability of job aids, and facility support supervision from the district. We've had an improvement in this domain from 30 to 95% in these facilities. Stock management, at baseline we were at 20. We've had an improvement in this to 78%. What we did was to avail stock books, stock cards to the facilities, and support them to learn how to place orders, documenting the stock cards and stock books, so they're able, and also how to calculate average months of stock, so they can place accurate orders. Procurement planning, family planning was omitted. Many times when the districts were meeting, they were not planning appropriately for family planning, and they were not using consumption data to do appropriate stock procurement planning. So this is something we supported the district to do every year, December, January. Reporting, many facilities, especially the private sector facilities, were receiving supplies. They order from JMS, which means that the stock is being consumed, but they're not submitting consumption data in the HMIS 105 for the commodities. So the NMS and JMS were asking where this stock, if the facilities are consuming through and we are seeing it in the orders, but we are not seeing reporting or service delivery in the reports, what's happening? So we supported them to make sure that we improve data capture and reporting by providing tools, mentoring them on how to document in these registers. So we registered the improvements there. I think the domain which is challenging, which has been challenging to us, and I know you, in your regions, if you try this, you'll find it challenging as well, is the stock management domain. So I felt we need to go a bit deeper in this and see what are the issues there. So it has a lot of components, about 7 components. But the components you see at the bottom, the 3 components, we have the correct filling of stock cards, accuracy of average monthly consumption, computation while placing orders, and correct use of stock books are the domains which we found challenging, although we've registered a bit of improvement there. So we continue to conduct mentorships to improve these areas. One of the key results, we've had an improvement in the couple years of protection attained from the family planning methods dispensed within the city. We've seen at the start of our project in March 2022, we were at 45,959, and now I think in July, September, we were at 98,000, which is a big improvement in the CYP. We also track an indicator on improving postpartum family planning uptake. The numerator for this is the number of women who have taken up a postpartum family planning method, and the denominator is the number of deliveries at the health facilities. So we've seen that an improvement in the clinical side of things as well, family planning clinical side of things. Maybe a key thing to emphasize if you are to register improvement is you can't achieve improvement in CYP without an improvement in uptake of long-acting reversible contraceptives. So at facilities, the challenge is that you'll find some of them lack focal persons to sterilize equipment, the IUD insertion kits. So you need to assign focal persons to support that process. In the private sector, postpartum family planning costs have been integrated into the delivery packages to boost uptake, and also nurse-led private family planning clinics in the private hospitals. One of the key things we had as a challenge is low order fill rate for family planning supplies. And also, I think last year we had IUDs which were delivered without the insertion kits. So if you look at most of the districts in the country, they have an overstock of IUDs because there's no insertion kits to support the insertion of these. So that's something that I think NMS needs to help us with going forward. And we have a new system at the regional referrals, EAFIA, which has come into an EMR system, which has come in to help us with improvement in data capture. But the challenge with EAFIA is some of the family planning parameters, timing, method, are not captured the way they are in the family planning register. So the EFR system needs to be aligned with the HMIS tools. So what have we learned? And the next steps, RxPass is a high impact initiative like you've seen, but a holistic approach is important. You can't do it alone as the supply chain team. You need to bring the clinical team so that you have a holistic approach. Digitization is coming in. We've seen EFR coming in. The EFR system needs to be revised to capture the parameters. It has to be aligned with the HMIS tools that we have. I think the last batch was in 2019, the HMIS tools. RxPass is not part of the pharmaceutical information portal, just like the other SPAS at emergency medicines.
I'm adding you just 20 seconds, please.
Okay, so I think this needs to be added there. And we need to expand SPAS to the private sector. I think the learnings we've seen here can be expanded to the private sector, which is the biggest part of the service providers in the city. Thank you so much.
Okay. Members, let's put our hands together and appreciate Martin. Martin, thank you so much for sharing on the RH SPAS. I've been knowing about the general MM and lab SPAS, but I think you're giving us lessons of integration of the family family planning mentors together with the medicines supervisors. We've been trying to do medicine and lab, but I think that is another good angle that you bring on the table. Ladies and gentlemen, let us invite our second presenter, Muhwezi Aaron, to share with us his views and lessons on improving rational prescription among clinicians. You're welcome, Aaron. 10 minutes, please.
Yeah, thank you, Session Chair. Good morning, everyone. Good morning, everyone.
Morning.
My name is Aaron Muhwezi, and I work with Mother Francesca Lechina Health Center for. It is a PNFP, and implementing the local service delivery for HIV activity under UPMBRSDA project. And I'm a clinician. I think I should be among the youngest in the house. And yes, and we shall try to focus on improving rational prescribing among clinicians at our facility, and we should be good to go. Just to add up on Professor Tumwini's presentation in the morning, we all appreciate that every country has a national drug policy, and Uganda also has one, which aims to attainment of a good standard of health for all Ugandans, and this is done through availability, accessibility, and affordability of all time of essential medicines. And these essential medicines should be of an appropriate quality, and should be safe, should be of high efficacy, and all this will lead to promotion of their rational use. Yeah, so rational prescribing is just a process of generating a written or verbal order for any drug to be administered to a patient, and this is usually in line with the guidelines. And we realize that it is pivotal for optimizing patient care, improving health outcomes, and mitigating the risks associated with the medicine's use, as we previously saw that there are very many risks that are associated with many medicines. We appreciate that there are prevailing guidelines on how to prescribe patients, but despite this existence, inappropriate prescribing remains a significant challenge across many health systems worldwide, and the same applies to Uganda and to our rural health facilities. And at our very facility, we benchmarked and understood that only 21% of our patients who had attended OPD had received appropriate number of drugs as of January 2023. So you can imagine many people were receiving a lot of unnecessary drugs. It was unfortunate that the alarm was first, or the whistle was first blown by the supervisors, not ourselves, but that was also okay. And it made us to open our eyes and get started. So the targeted mentorship was therefore conducted, and this aimed to at least enhance clinicians' knowledge about pharmacotherapy principles, evidence-based guidelines, and overall rational use of all medicines. This was preceded by one-to-one mentorship for clinicians who did not pick up quickly because we wanted to go on a rocket speed. And there we got started. We are happy to say that we have an OPD system which is online. We have an OPD system, so we integrated the clinical decision support system, and here the IT was on our rescue, where when you put in a patient's diagnosis in the system, then it was harmonized with the clinical guidelines, and therefore when you put in a diagnosis, you already see treatment options and how best you can be able to give it rationally. And it was a very big changer in our project. Yes, so we continue to foster the culture of collaboration and communication. Nobody should own a patient, but instead we discuss interdisciplinary, and we see how to move on with peer reviews and good feedback mechanisms, and shared decisions on some of the complicated conditions. So patient engagement was promoted, and patient empowerment was also done. And this was literally through counseling and shared decisions and adherence support interventions. This project was continuously monitored every month, and you can appreciate that following the interventions done, we saw an improvement from 21% to about 94% by July, and definitely this is still ongoing, and we are happy that now the majority of our patients are receiving the relevant number of drugs as guided. Yeah, so we think when we keep timely monitoring, and when we maintain our teamworks, and continuous medical education as well as CHI meetings, we can always reduce missed opportunities, and we still have an emphasis to be placed on the necessity of ongoing evaluation and refinement of the strategies to ensure that all through they will be effective in monitoring rational prescribing practices. And part of the lessons learned is that when we do targeted mentorship to clinicians, as well as evidence-based guidelines and critical appraisal skills, can always improve rational prescribing. Interdisciplinary collaborations are good. Communication among healthcare professionals is also very relevant, and it promotes and creates a culture of rational prescribing. Patient engagement is really pivotal and is really necessary, and empowering all these patients will also increase rational prescribing, and therefore people will not start saying, you have given me few drugs yet I'm very sick. So definitely on top of everything, leadership engagement is very paramount, and it increases commitment to rational prescribing. Yeah, so to conclude, so rational prescribing is improved across clinical disciplines, and approaches can always be targeted to ensure that this is improved. And by implementing all the strategies, then health care systems can always be able to mitigate the risks associated with inappropriate prescribing, to be able to optimize medication use, and this overall will lead to improvement in patient outcomes. I thank you very much for listening, and I look forward for the questions later. Thank you very much.
Thank you, Aaron. A big round of applause for Aaron, please. Aaron has lived within his time. He actually has spared us 2 minutes. Thank you so much, Aaron, for that sharing. Ladies and gentlemen, I just want to welcome our virtual participants, online people. We take note of your participation. At an appropriate time, you'll be part of the discussion. So I want to invite our third presenter, Philip. Ladies and gentlemen, let's put our hands together and welcome Philip. He's going to share with us his experience with leveraging WhatsApp platforms to enhance timeliness of orders in Hweju district health facilities.
Thank
Philip,
you.
you're welcome.
Thank you very much.
Yes, you have your
Session
10
here.
minutes, under 10 minutes.
My name is Philip Mhamia. I work with Hweju district local government. Professionally, I'm a nursing officer, but I am assigned duties of a district medicine supervisor. This morning we are going to share what we innovated recently, leveraging on WhatsApp platform for enhancing medicines and health supplies availability in Hweju district health facilities. As part of the introduction, like as the session here mentioned, access to essential medicines and supplies is critical for the quality of healthcare services. And the consistency of having these medicines in our facilities is dependent on so many processes, including planning, ordering from warehouses, specifically for the public facility. Of their facilities met the deadlines. Two, resource constraints. We are still living in Uganda, a resource constrained country, and so we could not do on-site mentorships to health workers. And also there are the method of rotating health workers, of course, transfer from one facility to another. So there is need for continuous mentoring of these health workers. And so working with you said, RMNCAH, our partner, our IP, we thought out to use the WhatsApp, a widely used social media platform where every one of us, I guess, each one of us uses it to contact our colleagues. Next slide. Yes. So we formed a group comprising of selected facility staff. Each facility with this system has preparers and approvers, where the approver is the in charge. The district logistics focal persons, the DMMS, the MMS, and some DHT members, because we have program items. We also included in the NMS regional coordinator and technical staff from the IPs. And on this, we shared CSSP content, both audio and visual, during the cycle 3 ordering period. And then also would remind colleagues 2 weeks before the order deadline. And on this platform also, staffs would seek clarification on how they would go about the new system. And they would get instant feedback on the group. This is just a pictorial view of what transpired on that platform, specifically for CSSP. And staffs would ask so many questions. Sometimes this system has challenges with the passwords. Every time you want to order, you've got to put in a new password. And so would give instant feedback. And our results, this innovation improved the timeliness of orders by 100% order submission by cycle 3. On the left of the screen, that table was during the cycle 1. Very few facilities actually submitted their orders on time. By cycle 2, during the implementation, some people had picked up. We can see some greens. That is table 2. But by cycle 3, all the 9 facilities, here I mean we looked at facilities that order essential medicines and program orders. By cycle 3, all facilities submitted their orders on time. And we noted that CSSP was a shift from paper-based, and it was a new concept. But because of so many challenges, including limited resources and the lack of the IT skills by the staff, we thought to use WhatsApp to specifically address the skill gap. And WhatsApp being a commonly used social media platform was very effective for us. And when we checked in our system, more than 90% of our health workers owned smartphones. And so it was an opportunity for us to leverage on that to mentor our staff online. And we noted that using this, using WhatsApp, there was instant communication and knowledge transfer. Because you would even check, once you send a message, you can even check on who has received and who has not even received the message you've sent. So it was instant. There was also improvement of staff confidence in using the system. And also, we also noted that actually using WhatsApp can improve communication in healthcare settings. And so we recommend that we should embrace virtual mentorship programs, especially using familiar social media platforms like WhatsApp. But also, if it's possible for the ministry, IT innovators should think of having electronic health systems that use such simple social media platforms, because these platforms, we engage with them regularly. So if you can have electronic health systems that can be embedded within these simple platforms, they can help improve in communication in our health settings. I want to acknowledge all these people, but most especially the UHS, you said LPH and Kore. These people provide us with even some airtime bundles to our staff. I also want to acknowledge my boss, the DHO and the DHT, and all other stakeholders. Thank you very much for listening to me. I await for the questions.
Yeah, thank you so much, ladies and gentlemen. A big round of applause for our brother Philip. Again, he has saved us 2 minutes. Philip, quickly step and take your seat. Friends, my approach is that we are going to cruise through, and when you go into discussion, we go to the discussions once. I'm not doing a first day presentation and discussion. I think that will be longer, and the Secretariat has agreed with me. Let's invite our fourth presenter, Patricia. Let's put our hands and welcome you people. It's not easy to step here and make a presentation. Patricia is going to be sharing her experience on data-driven malaria commodity management, experience addressing discrepancies, ensuring accountability, and realizing billions in savings through political engagement in the Busoga region. Patricia, you're welcome.
Thank you so much. Good afternoon, everybody. My name is Patricia Mukose. I work and serve the President's Malaria Initiative, malaria reduction activity. I'm an M&D officer and I work in Busoga region. I'll be presenting an abstract entitled Data-Driven Malaria Commodity Management, Addressing Discrepancies, Ensuring Accountability, and Realizing Billions in Savings Through Political Engagement in Busoga region. So Uganda has 15 administrative regions clustered geographically, with West Nile, Busoga, Teso identified as regions with high malaria mortality rates. Busoga region has a malaria prevalence of 21%, notably higher than the national average of 19%, according to the Malaria Indicator Survey 2018-2019. The National Medical Stores, that is NMS, is mandated to procure, store, and redistribute essential medicines and supplies to all public health facilities in the country based on defined commodity needs and available funding under the credit line. The health commodities are delivered to health facilities on a 2-month cycle basis. However, challenges with inconsistencies, not only in delivery of drugs by NMS, but also fulfillment of commodity order quantities have been reported. So MRA used DHIS2 data to identify discrepancies in malaria rapid diagnostic tests, also called MRDTs, consumed versus actual tests done, as well as difference between artemethylumefantrine, commonly known as AL, consumption and treated malaria cases. So what did we do? When we saw these discrepancies, we were wondering what is happening in the health facilities. Is what we are seeing in the DHIS2 system, is what we are seeing in the system also coming from the facilities? We wanted to ascertain, is what they are reporting, what is coming from the health facilities? So we did what we call integrated support supervision with the DHTs and the MRA staff. We went through facilities that were giving us the biggest inconsistencies or discrepancies, and we did support supervision. We checked through their stock cards, OPD registers, dispensing logs, HMIS 105, 108, and their monthly reports. So after getting this data, we had to do what we call a performance review in all the 11 districts and 1 city, that is Jinja City. So during the quarterly malaria performance reviews, across all the 12 districts attended by, we invited the district leaders, including also the political leaders, the LC5 chairpersons, we invited the whole DHT, we invited health facility in charges, store managers, medical records assistants, collaboratively evaluated the malaria situation and commodity management in their respective districts and health facilities. We disseminated the findings from the support supervision. So what we see is just a snapshot of what was happening in the DHIS2 system. When facilities are reporting AL, that is artemether-lumefantrine, they report in tablets. So you convert tablets into doses because one patient equals one dose. So for example, take an example at Namunyu Health Center 2. Only in April, they reported that they consumed 23,760 tablets. That is 1,373 doses. So they used 1,373 doses to treat 877 patients. Remember, it is one dose, one patient. So what you see in red as variances is what was unaccounted for. You can call it a variance, unaccounted for, or any other word you can choose. So we also looked at MRDTs, only 2 drugs, AL and MRDTs. For MRDTs, we can take an example at Namugongo Health Center 3. Only in April, and these are only 5 facilities. We have over 483 facilities in Busoga region. So Namugongo Center 3, in April, it reported that they consumed 5,500 MRDTs to test 1,160 patients. It is one test, one patient. So what happened to the 4,340 MRDTs? They were unaccounted for. So the major gaps identified when we went to do that support supervision, what did we see in some of the facilities? In Bujiri district, I will not mention the facility. We looked through their stock cards. So on seeing the stock cards, that facility had a balance, or had had a balance of 78 boxes of MRDTs. When you get 78 and you multiply by 25, it's about 1,950 tests. So we looked for the 78 boxes of MRDTs, but we couldn't find them. So we asked the health worker to show us where the boxes were. So she said the boxes were in one of the boxes, the big boxes that was sealed. It was properly sealed. So we asked her to open. She fidgeted, and later she opened. But ladies and gentlemen, we only found books. There were no boxes of MRDTs. So we wanted to give her our feedback, but we couldn't find her. She disappeared from the health facility. In Iganga, majority of the public health facilities reached, had missing commodities, and could not account for them properly, which was probably explaining the stockhouse in some facilities in the district. So the actions that we took. Action plans for all health facilities reached were developed to improve stock accountability and continuous mentorship with DHTs and PMI MRA team to track progress. We also conducted performance reviews across all the 11 districts and the 1 city. We invited the political leadership, the LC5, we invited the CAH, we invited the RDC, the district planner. Yes, you can see Human Resource Office, we invited them because they are the ones that pay these people, our health workers. We invited the PAS, the health facility in charges, and store managers, and deliberated on the way forward to reduce drug pilferage and poor accountability. Joint support supervision, Bujiri is a special case because when the LC5 chairman saw what was happening during the performance review presentations, he was interested. He wanted to actually go and see if what we are saying is true. So because he asked us to support logistically, we did so. We supported the whole DHT. We supported him. We supported the CAH, the DHO. We went along with them, and they checked and they saw what we saw. So what did Bujiri LC5 do? With the GISO and the RDC, they trailed the buyers of these commodities, and were arrested. This reduced pilferage of AL and MRDTs from all the Bujiri health facilities. At least most of them reduced this behavior. So what were the results? Between January 2022 and Feb 2023, NMS delivered 4.61 million MRDTs, but only 65.8% were used in health facilities in only Busoga region.
Patricia,
and only one
minutes.
drug.
2 minutes. You could.
Thank you. Similarly, 3.39 million doses of artemether-lumefantrine were supplied with 71% used for malaria treatment. Notably, 843,000 ACT doses and 1.4 million MRDT tests were unaccounted for. So we put this in monetary terms. And we found out that a potential monetary loss of 6.8 billion Ugandan shillings was gone. After presenting this data, accountability improved in districts like Bujiri, where unaccounted for AL doses reduced from 15,199 in October 2022 to 1887 in May 2023. And MRDTs reduced from 885.17 in October 2022 to 2738 in May 2023. So engaging administrative and political leaders in performance review meetings and integrated support supervision in health facilities has proven beneficial for districts. This involvement not only helps maintain drugs availability in health facilities, it minimizes stockouts, also providing a clearer picture of the malaria situation in the districts. Thank you so much for listening to me.
Members, she deserves a louder applause. Patricia, thank you. Thank you. Quite an insightful presentation. I'm sure the health managers are listening. Sometimes we supervise proliferage of items unknowingly because we are not peeping into the data. I think that was very insightful. Let's move on to our fifth presenter, Ruth. She's coming to share with us an abstract on increasing the proportion of HIV positive women screened for cervical cancer at Rukunyu Hospital. So Ruth, you're welcome, and you have under 10 minutes. And if you could move faster, by the next presenters, don't spend a lot of time on introduction. We want to know what the issue at hand and the results and the discussion. The discussions, the introductions should not waste a lot of your time, given where we are with the time. Thank you.
Okay, thank you. Good afternoon, team. I'm Ruth Timbigamba, midwife working at Rukunyu Hospital, Kamwenge District. I'm presenting increasing the proportion of HIV positive women screened for cervical cancer at Rukunyu Hospital. The Ministry of Health recommends that 100% of eligible, that is 25 to 49-year-old HIV positive women, should receive cervical cancer screening as part of their routine HIV care services. By September 2022, Rukunyu Hospital in Kamwenge District had only 33% of the enrolled HIV positive women screened for cervical cancer, leaving a gap of 67%. A root cause analysis was performed. This was done through the 5 why, the brainstorming. We found out that the contributing factors included capacity gaps of cervical cancer screening, no line lists for eligible mothers for screening, mothers' files not updated with cancer screening results. The hospital team developed a quality improvement project to increase the proportion of HIV positive mothers 25 to 49 years screened for cervical cancer to target achieving 90% by the end of March 2023. This was done through technical mentorship to the facility team, and this was done by Bella Uganda through supporting the district health team. And through this, cervical screening data review and root cause analysis was done, and which was done by the work improvement team, which reviewed the files and registers to clearly identify where could be the gap as far as documentation is concerned. Then also we continue to have weekly data review and complete documentation of cervical cancer screening due dates in client files. Here we had to assign someone who will be reviewing documentation and sharing at the weekly meetings. We also had to make line lists for all eligible mothers, display the lists, and also engage the linkage and referral assistants to do the community mobilizations. These linkage and referral assistants and the peer mothers, we work with them and they are being employed by Bella Uganda. So we only give them the roles and responsibilities to assist. That is our results. As we started from 33%, we managed to improve by February to 94%, but in March we had again to go to 90%. And some of the challenges will be shared in the other slide. Mechanisms that routinely identify eligible HIV positive women and streamlining of documentation processes were key factors in improving cervical cancer screening. As you can see on that photo, we had to put in documentation. We found out that we had a gap of documenting when we do cervical cancer screening to our clients. We could find some mothers are screened, but there is no any documentation in the client cards, and also the EMR is not being updated because of that gap. Lessons learned: conducting root cause analysis is key to identifying successful countermeasures for gaps at the facility. Having line lists for eligible mothers guide service provision at contact with the mother, because we are already aware who is going to receive the service for cancer screening, so it was easy to handle them. Implementation of changes like line listing clients eligible for cervical cancer screening and recording due dates in client care cards can improve cancer screening uptake. Recommendations: continuous and routine support, supervision for cervical cancer screening. We noted that it is key, and we recommend it to be continually done to even other facilities. Strengthen the referral system for the identified positive cervical cancer clients. This was among the challenges whereby we could find we have the positives, but the referral system was quite tricky as we had to refer them to the regional referral hospitals. Availing adequate instruments for cervical cancer screening like speculums and forceps, and among others. Due to being a public health facility, some of the things we could find that we don't have. But we appreciate Bella Uganda that had to support us, especially when it comes to JIC and other things required. I acknowledge CDC, acknowledge Bella Uganda, and on a special note, appreciations to Dr. Juko Richard, to Dr. Farida Akuju, to Dr. Andrew Katawera. Appreciations to Kamenge District Local Government, the DHO and the DHT. Appreciations to the CHY team, Rukunyi Hospital. And appreciations to the MS, Dr. Mjune Ivan. Thank you.
Another big round of applause for Ruth. Thank you, Ruth, for sharing the experience and again saving us a precious 4 minutes. Thank you. So let us move to the 6th presentation, and that will be, is that Richard? Yes, Richard Kimaka, HMIS approach to improving maternal and child health service delivery, application of that MNOC tool. Richard, you're good to go. 10 minutes, please, or under 10.
Okay.
We shall be grateful.
Thank you so much. Good afternoon to you all. I'm Richard Chimaka, Monitoring and Evaluation Manager, Babies and Mothers Alive Foundation. I'm here to present a health management system approach to improving maternal and child health service delivery, application of maternal and neonatal obstetric complication survey tool, MNOCS, in Rakai and Chotera districts. First of all, I would like to acknowledge my co-authors. Babies and Mothers Alive Foundation is a local NGO based in Rakai, Chotera, and Masaka districts, supporting reproductive, maternal, and newborn health service delivery since 2015. And in partnership with local district governments and Ministry of Health, its aim is to reduce maternal and perinatal mortality in the service area. And this is done through demand generation, improving access and utilization of maternal and newborn health services, improving quality of care, and then strengthening the health management information systems. As we all know, Uganda has taken a significant step in reducing maternal mortality. However, the pace is still suboptimal to reach the SDG target of less than 70 deaths per 1,000 live births. So the current statistics on maternal mortality ratio in Uganda stand at 189 deaths per 100,000 live births, and infant mortality at 36 per 1,000 live births. And that is according to the 2023 UDHS report. So BAMA, focusing on improving maternal and newborn health service delivery, designed an MNOCS tool that provided evidence-based statistics on prevalence, causes, and consequences of all maternal and newborn complications for formulation of interventions that could address the 3 delays in accessing emergency obstetric care. In 2016, a simplified MNOCS tracking tool was used to conduct a baseline survey in 48 government facilities in Rakai and Chotera districts. And this was followed by routine monthly data collections to capture a line list of patient data on births, maternal and newborn obstetric complications, as well as the delivery outcomes. As we can see from the cycle, the visual cycle, so the selection started from, the process started from the selection of a midwife and data entry pair at the host facilities who were trained, and this was followed by the routine monthly data collections, and this also was followed by the triangulations of the data captured from the primary data sources. We all know that sometimes there is missing data in these registers. For example, a C-section that was conducted without an indication for Caesar was being translated from a theater register book. And all maternal dates, and sometimes when it comes to maternal dates, these dates are not recorded directly in the primary register, which is the maternity register. They are recorded in some other sources, like the nurse's handover report books, the notification books for maternal and review books. So the triangulation was done. And after triangulation, analysis of data, of maternal and newborn obstetric complications data, and data quality and quality-based indicators was done, and results shared to a different level at health facilities and district level during the performance review meetings that were conducted. In the performance review meetings, action matrices were generated, and interventions geared to quality improvement were selected. Below, you can see a screenshot of the MNOCS data entry screen, having all the parameters as captured in the maternity register. Yeah, using the MNOCS results, the MNOCS results guided the implementation of high impact and low cost interventions, and these included the targeted capacity building trainings and mentorship for health workers, the strengthening of emergency referral systems, establishment of adolescent-friendly reproductive services at the health facilities, establishment of NICUs, neonatal intensive care units at CMOC sites, and also intensified the community awareness campaigns. So these data-driven interventions, in turn, contributed to the improved maternal and perinatal outcomes, as we can see from the graph. Looking at the institutional maternal mortality, this averagely improved by 74%, considering the baseline year of 2016. And the perinatal mortality ratio also improved by improved averagely by 48% across the implementation years. So the same applies to the obstetric case fatality rate, which also improved by 69%. So we can also as well see the MNOX tracking system showing us the prevalence of the major obstetric complications across the period. Furthermore, using the MNOX data, met need for emergency obstetric care could be calculated easily, and using the data-driven interventions, they contributed to a 24.3% change in the met need for emergency obstetric care. And the interventions that were geared towards the reduction of neonatal mortality, such as the implementation of the establishment of NICUs at CMOC sites, also helped in the saving of the sick newborns admitted at the facilities, and we can easily see a rising trend in the survival rates of babies discharged at these facilities. So furthermore, the results showed a 91.3 quality documentation observed in the primary registers, and this was because the MNOX tracking system was used also as a validation tool, whereby health workers were later trained on use of right codes and generating data that has no missing parameters.
Richard, you have 2 minutes.
Yes, from our discussions, strengthened routine HMIS led to higher quality data and efficient health information products that guided program monitoring and planning, and this enhanced quick accountability and utilization of data by health stakeholders. A 2015 report on implementation of the USAID's M-chip in low and middle income countries showed similar results. Lessons learned: optimal utilization of high quality HMIS data supported the formulation of high impact and low cost interventions, which in turn improved the maternal and newborn health outcomes in Rakai and Chotera districts. As a recommendation, the MNOX tool can be used as a benchmark to improve DHIS routine upgrade to capture summarized comprehensive maternal and newborn indicators, and having such a system at health facilities will further strengthen the HMIS data quality and usage. Thank you so much. I would like to acknowledge the partners working with babies and mothers alive to improve maternal and newborn health in Rakai and Chotera districts. Thank you.
Yes. Thank you, ladies and gentlemen. Let's put our hands together again and appreciate Richard for sharing. Thank you, Richard, and for keeping time. Ladies and gentlemen, I seek your indulgence. I've been advised. We are honored to have our Honorable Minister in the House. We are going to interrupt our presentations. We have sampled at least 6 out of the 9, Dr. Kware, the presentations, and in the interest of time, I've been advised that we end at that point. And my apologies to the remaining three presenters. We have to fit, sorry? They can? Okay, fine. Thank you. Let's put our hands together. The Honorable Minister has given us a few additional minutes. Now we are going to use those minutes very, very sparingly for the next team. And I also seek your forgiveness, since the theme is innovation, because you are living in a resource-limited setting. The podium is full, so we have improvised. The presenters, bear with me. I'm not discriminating, but we are just innovating. So without wasting much time, let me invite our seventh presenter. Please skip the introduction. This time I'm strict. Please go to the methodology results and your recommendations. Let us put our hands together and invite Joel Kakaire to share with us an abstract on relying on technological innovations for social networking strategy in improving HIV case identification. You have 5 minutes to make your case, Joel. Thank you.
Thank you. Thank you, the moderator and colleagues. My name is Joel Kasakaire. I work as the Quality Improvement Officer for USAID LPHS Local Paternity Services that is being implemented by Makerere University Joint AIDS Program. Yes, briefly today we are going to have a learning from one of the health facilities in our region. Briefly, we support 12 districts within the EC region, and one of our innovations is from one of the health facilities we support. We are going to have a learning about scaling up the implementation of the social network strategy, improving case identification, and we're going to have an experience from my Girl Center for in the EC region. Colleagues, we all know about the triple 95. Basically today we are going to focus on the first 95. You realize Uganda adopted the target HIV testing services, implementing through high yielding approaches such as index testing and the SNS, that's the social network strategy. However, in the EC region, we rolled out this SNS approach as one of the approaches to improve case identification during 2022. And by July-September 22 quarter, the region had 73 clients documented to have received HTA through this approach, identifying 4 new positives with a 5.5%, and all these were linked. However, we went ahead by December and went to Mayuge Health Center for. So we did
remember you have 5 minutes.
Yes, please.
I'm going to be strict.
So we did a root cause analysis, and we identified that knowledge gap among health service providers and lack of the dedicated performance improvement team, inadequate data capture tools, and challenges with the testing kits. So as one of the strategies to improve the performance, we conducted an SNS specific orientation and mentorship of the multidisciplinary teams from all the departments, secured key SNS data tools and record personnel oriented in proper SNS data management. We allocated SNS specific target and weekly milestones agreed. This were trying to make sure that the facility teams embrace data utilization. We secured testing kits from other facilities and started a quality improvement project to address these gaps. Sorry. As you can, after applying all the implementation strategies, you realize our TST, total number tested within this approach, increased from 0% December 20 to 156. Then also the positivity rate, also identification of the TST positives, also increased from 0% to 178 against the annual data, against the annual target. So in conclusion, this positive trajectory in the total number of HIV positives identified by the facility was mainly attributed to the scale-up of the SNS data testing modality, since it was the only new intervention implemented and the rest were the enabling factors. Acknowledgements, we acknowledge PEPFAR, USAID, and also Uganda Ministry of Health, the district local government, then Makerere University Joint AIDS Program, and other partners in the EC region. Colleagues, we don't work alone. We work in collaboration with the other partners in the region as a team. In a special way, I want to thank Dr. Moses, Dr. Fred, Semtala, and Dr. Samuel, plus Kimba and Michael. Thank you so much.
Yeah. Thank you. Members, let's put our hands together and appreciate our brother. He's been able to live within his 5 minutes. I salute you for that. So our second last presenter is going to share with us an abstract on relying on technological innovations for quality improvement in Chigezi. And please let's welcome Didas Muhwezi. And Didas, please live within 5 minutes.
Okay, thank you so much. I'm Didas Rutunje Mwezi, the Regional Quality Improvement Officer, Kigezi Region. I'll be sharing with you about the technological innovations to improve quality improvement in our region. And before even I go ahead, what we are doing now here is relying on our technology to have people virtually attend with us here for us who are physically present. As you well know, disseminating the innovations or initiatives across the healthcare system is most times challenging, but it is potentially achievable. We have a number of these platforms.
Just adjust your mic so that you can go.
Okay, thank you. We have relied on Zoom, the WhatsApps, the Google Meet, the TeamViewer. The previous presenter from, I think Sinjiro, talked about one of them. And the key to note that the moment we leverage on this, we shall be able to have some of our initiatives on the drive. Key to note that besides some of them work in certain areas, in some other settings they may not operate, but however, we are going to share how it worked in our region. There are common reasons why spreading such an innovation across the system is always hard, and to achieve this, most times it requires teams to be having a better internet connectivity, which is a challenge across most regions, like for us in Kigezi, being a hill area, and challenged with the network. It could be one of the issues. Most times staff are always busy. To divert them from their daily work to join these Zoom calls, it's always actually also challenging. Again, one is commitment. To find that one is really committed to come and join virtually, attend a learning session, attending a meeting, is also always a challenge. And there are also those deeply held professional norms. Maybe you are a surgeon, you are in a theater, but have a meeting to attend, and shifting that it also becomes a challenge to be part of this virtual innovation. The method is following the request from MOH, USAID. The region is we have key priorities to be implementing, and in that way we are functionalizing the regional QI activities. A number of them were listed, those which are to be done in that period, and we mapped the specific participants for those specific activities. We have been able to generate the meeting links and dates for those meetings to be shared. The activities are quite many, we shall see them ahead. Various WhatsApp groups were formed for those specific activities, specifically to guide on communication and also coordination. A number of the stakeholders were mapped and were part of these platforms, and were able to generate all the mailing lists for these other stakeholders. We can see in our results, actually, even if I share, most times QI interventions are rarely adequately funded. So that's why you have to leverage on such platforms to have a move of these interventions. As a region, we're able to conduct our VMM safety committee meetings virtually. We haven't had a physical one, but they've all been very successful on virtual platforms. Through the community health department of our hospital, under the hub and spoke, 8 CMEs have been conducted with the lower facilities, with support from UHSS. All the CMOC sites, high-volume sites, have virtual platforms, and we're able to engage them and have the CMEs. The learning meetings, weekly, we conduct learning meetings, and a number of them were done. And also orientations for a number of the collaboratives. Here specifically I talk about the maternal risk identification, response and retention, which have been also done virtually. And lastly, among many others,
you have 1 minute.
Regional JRM, that is for Kigezi, we're able to also organize it basing or utilizing on these virtual platforms. And just I picked out one of the activities, which was the JRM. The trend, the number of participants that were joining online. We had a number of meetings, around 20 of them, but you can see we maintained a number of them online, and most of the stakeholders in the house, and they can witness that. So we did a cost-benefit analysis. In the case we had to hold these virtual meetings physically, how much could it cost, and how much could it cost maybe going virtually. So you can see an example, like having one physical meeting could go around 9.7 million. So assuming we had like 5 physical meetings, the rate could go as high as 48 million. However, besides this cost benefit, there are also very many implications which I have to put into consideration, especially the quality of the meetings, have a bit of data, which most times people complain about, and also time of meetings are not friendly, not forgetting our IT literacy. That's an example of one of the outcomes of our virtual engagements. What can we learn from here? Leveraging on different virtual opportunities can improve implementation of QI approaches or initiatives leading to better care. And when teams get accustomed to these platforms, they tend to actually adhere to them, and this improves on the coordination, especially leveraging on the WhatsApp and Zoom. In conclusion, technological innovation, especially virtual meetings, have enhanced engagements in the region. They have bridged the geographical gaps. As you know, the region is hilly, actually it's mountainous, so most times this has bridged the gap. And also, based on the limited budgets, it's like hiring conference rooms and other facilitations, we have been able to achieve this this success. I want to acknowledge
Thank you, Didas.
our stakeholders.
We acknowledge
who are
them.
also here.
Didas, your time
Thank
is
you so
up.
much, and I wish you all the best.
We've seen that acknowledgement slide. Thank you. Thank you, Didas. Please, Didas, I'm sorry, but we have to live within the little time the Honorable Minister has given us to finish. Please, let's put our hands together, and we welcome the final presenter, Simba Wilfred. He's going to share with us the influence of nationally led mentorships in improving the performance of QI collaboratives, lessons from the dreams. Simba, you have tried to live within 5 minutes, and we see how we conclude.
Good afternoon to you. It's okay, Innocent. I work for Makerere University School of Public Health Mates Program as a technical advisor, M&E. I also support QI. So I'm going to present on the topic, influence of national-led mentorship in improving performance of the quality improvement collaboratives. We are learning from the DREAMS collaborative conducted in the CDC region. DREAMS is one of the comprehensive responses aimed at preventing and controlling HIV infection among adolescent girls and young women and their impacts. When you look at the national HIV prevalence, the females or women have a high HIV prevalence. And when you look at the HIV incidence, we find it's high among the adolescent girls. And when you put focus on the on the new infections, still we have a higher number of adolescents acquiring HIV. So given that background, MOH came up with a national Dreams 2I collaborative aimed at trying to avert some of those figures that we see up there. And some of the objectives of these collaboratives included increasing of the male partners of the adolescent girls being circumcised, then enrolling these adolescent girls onto the program, and enabling the adolescent girls access family planning counseling. And the last one was to do with increasing the uptake of family planning method by choice amongst the adolescent girls and young women. So we reviewed data to identify the 2I.
Simba, remember you have 5 minutes. You should be progressing.
So we reviewed data to identify the 2I priorities, developed a change package, oriented the teams on that change package, conducted on-site mentorships, conducted a learning session, and then developed the change package that was disseminated later. So we did a national capacity building campaign for the district and IP coaches, then involved the national mentors and coaches on a quarterly basis to visit these facilities. And then we also had national aid coordination meetings that we used to do regularly. And the last intervention was integration of the health facility youth peers and the Dreams focal person. We saw an increase in the number of male partners of the adolescent girls circumcised, increasing from 60% to 96%. Also saw the number of adolescent girls initiated on PrEP increasing from 60% to 99%. We saw the number of adolescent girls accessing family planning services increasing from 69% to 96%, and the number of adolescent girls receiving family planning by choice, of their choice, increasing from 81 to 96%. So we are saying that involvement of national coaches in these collaboratives is very important. Training of the district coaches and IP is not a one-off item. We need continuous mentorship and involvement of the key subject matters. I acknowledge PEPFAR, MOH, district local government, IPs, and the health facility teams.
Yeah, thank you so much. Members, a big round of applause for, I'm very sorry, but we've been living within borrowed time. Ladies and gentlemen, that ends our presentations from the 9 abstracts that were due for this session. Let's put our hands together and appreciate our 9 presenters. A big round of applause for doing a needful. I'm going to ask Dr. Martin, you come and advise. Can we take 1, 2, 3 questions? I'm now in the Honorable Minister's borrowed time, but I needed to be guided. We have had 9 presentations. Martin, you could advise me. Do we take 1, 2 questions? Do we? Okay. Members, a big round of applause for the Honorable Minister once again and the Director for giving us an opportunity to field in a few questions. Given that we are living in borrowed time, please don't meander. Give us short questions, short comments, and 1 question per person. We are going to take 1, 2, 3, and that will be a sample for the rest of us. 4, the other lady over there. Please be precise and to the point.
Thank you very much, Chair. My question goes to Aaron. Drug promoters vis-a-vis rational drug use. How did you manage to address the construct of drug promoters?
Thank you. Move quickly.
Thank you,
Okay.
Chair.
Yes.
Chair, I want to thank all the presenters, but I also want to appreciate the innovations that have been made for promoting 2I and improve all our health services delivery in the country, and all I do appreciate. But however, I wanted to just think about What about the issues related to, we all understand the 6 building blocks in health delivery, and where, much as we have innovated, the resources are still small, but we still continue to innovate. And the principles of 2I is we must continue. But I wanted to bring the issues of urban health. Urban health has been innovating. Yesterday, Grace presented something related to VHTs. I don't think how VHTs are going to work within the urban cities and Kampala city.
Lastly, wind up your statement, please.
I just wanted to appreciate.
Okay, thank you for the appreciation. Yeah.
Thank you so much, Chair, and thank you to all our presenters. My question goes to Mr. Muhwezi. You spoke about a system that you are using as one of the interventions where clinicians enter the diagnosis and the available or recommended treatment options automatically come. Could you kindly share more about that system? It could be of help to other facilities. Thank you.
Thank you so much. The presenter who presented about improving rational drug use, I would like to know how you were collecting the data, the time frame. Was it daily, weekly, or monthly? Because it seems it is a very huge amount of work to be done on the period of time, like the monthly. Thank you.
Thank you. Last question.
Yeah, thank you very much, the moderator. Mine is about to, it goes to Ruth Timbigamba. There was significant increase in cancer screening among women in their project. But I would have loved to hear about the positive outcomes. Did the screening yield positive outcomes, such as having the women with lesions given treatment, things like that? Because most often we are challenged with having acetic acid at facilities and things like that. And the screening program should actually be effective in identifying the cases. Thank you very much.
Okay, thank you. I think, ladies and gentlemen, you will forgive me. We are going to end at that point. Maybe as a session chair, I will do 2 questions. 1 question and a comment, so that I don't lose it all. I wanted to ask Aaron, you presented, we have been struggling with the polypharmacy. I wanted you shared about 3 changes, mentorship, the integration of the clinical decision support system, and then you talked about the culture of communication and collaboration. I just wanted to ask you, which was the game changer? I saw the system looked like one would have to consider a game changer, but you put it as a 3rd intervention when you've almost hit your target. I'm not sure whether at what point the system came in, because I loved your system. And then lastly, Honorable Minister, we had an experience from Jinja, Busoga region, where data was used in driving the issues of discrepancies in commodity management, and that resulted into a stakeholder engagement and recovery or arrest of people who were found with maybe government drugs. I think it was a lesson. I just wanted to say that was a very big lesson for us health managers, that we have now a DHIS2 which virtually can give you whatever you want, whether test kits for HIV test kits versus the people tested, or malaria kits versus the malaria tests. And we have our some of our health workers, they are few, but they are there, who will beat the system. But when you use the system, again, you can be able to capture. So I found it very interesting. I hope all of us who manage health workers saw that our system can pinpoint where the problem is, and they can lead to an intervention. So let me go back to the presenters, the way you did it, 1 minute to respond to the questions that have been posed. Thank you.
Yeah, thank you, Session Chair. I think I am the one with most of the questions. Once again, my name is Moez Aaron, and I was talking about rational drug use. So I want to begin with my brother who asked about drug promoters versus rational drug use. Yes, I must say that during improvement of rational drug use, there are very many challenges, and we definitely have a lot of drug promoters and a lot of drugs coming, in the end users. But I want to say that we encouraged to sticking to the guidelines, and that the Uganda clinical guidelines, and any drugs that are promoted are not, in our formulary and in the guidelines, then we are not encouraged. About how we collected data and about the system, I think facilities that are already using this open MRI system at OPD are trying to get what I'm saying, but summarize it is just a system where a patient comes at triage and goes online up to discharge at pharmacy. So how we really used it is that once a clinician does everything and reaches on a diagnosis, I would say, let's say I have diagnosed malaria, then the drop down comes on the treatment options, and this is already integrated with the clinical guidelines, and I can see that I need to prescribe, maybe methylmephantrin as it is my first line that is recommended. So that is how it works, and it is good to go. Those of the facilities that are really using the system can testify. And finally, my session chair, yes, the game changer, true, the system was the game changer, but of course, bringing it third was just to make sure that I tried to go chronological on how events started to reach on this success. Thank you very much.
Okay, thank you, Aaron. I think let's exhaust the presenters on my left. If you have a question, okay. Ruth?
Okay, thank you very much. For us at Rukunyu Hospital, we noted improvement, and we had positive outcomes in that they identified positive women with cancer were managed. At our hospital, we managed to do thermocoagulation, and those ones that we are unable to manage, we refer them to the regional referral hospitals. Then also another impact that came out, some clients could come, attend the Art Care Clinic, but don't reveal other concerns as far as STIs are concerned. You inquire from a client if there is any problem, would say there is nothing. But when we go for cervical cancer screening, we find that this client is having STIs, and this one helped clients being treated. And also another thing that helped us, through this cancer screening, other clients that we screened were motivated to encourage others to also come for cervical cancer screening. And some clients could even come on demand. Thank you.
Yeah, thank you. Colleagues, any other person with a response? Okay, so thank you so much. Let's put our hands together, ladies and gentlemen, and appreciate again our presenters. Thank you. And thank you for being a wonderful audience. To the virtual audience, we are sorry we've not been able to pick their issues, but I think we can follow the chat after the closing ceremony. Thank you so much, and we are adjourned this session. Thank you for your attention.
Thank you, Chair. Members, you can give the chairperson another big clap for leading this session. And we also appreciate the presenters that have been able to share with us with a big hand clap. Colleagues, we are sorry we have had to merge the sessions here because we are moving the session we were supposed to have at the end. We are bringing it forward due to unavoidable circumstances, but also the commitments that are at the decks of our leaders here. So before I tell you what we are going to go through in this afternoon session, we are joined by our Honorable Minister, and I want us to welcome her with a big hand clap. So we are going to have a brief session which will have about 4 items, and this will be chaired by our director, Dr. Joseph Okware. We are going to have remarks from our partners who are here from CDC and PEPFAR, and also we shall have an address from the minister, and at the end we shall have a short ceremony to recognize some of the best performing facilities in the assessment that was done in some parts of the country. So I would like to call upon Dr. Joseph to step forward and lead us in the next session.
Thank you very much. The MC. I'm trying to adjust this microphone, Honorable Minister, to fit this abnormal size. Okay, so first, apologies really